Thank you so much for joining me today. So to get started, how is your institution taking precaution against COVID-19?
Over the last 3 to 4 weeks, we've made enormous changes in the way we do business to try and be prepared for a COVID-19 surge. So we started really with basically changing most of our clinic visits to televisits. So currently we're doing most of them by phone, but later this week we'll be rolling out video visits with patients. So the reason for doing that, of course, is to avoid patients coming into the clinic, allow social distancing in the clinic, have less people in the clinic. So that was the first thing that we did. We subsequently moved to kind of a doc of the week for each of our disease sites. So there's one of the breast oncologists in the clinic every week, one of the lung oncologists in the clinic every week, and they do all the in-person visits, which actually, interestingly, are very few now. We're doing almost all of them by phone. Actually, the patients really appreciate that because they don't want to come into the clinic if they can avoid it. So it's actually worked pretty well. And I think, unlike other institutions, we're also doing it for treatment visits. So patients that need labs and chemo, they come and get their labs, go up to the chemotherapy infusion center, and then we call them on the phone up there. The nurses let us know when they're there, and then we call them up there. So again, it's just avoiding them going to another part of the hospital, thereby lessening the chance that they could pick up the virus. And then last week, we actually collapsed our hematology service into our BMT service. So we usually have 3 services, but now we just have 2. So again, the reason for that is that we are doing less transplants because of COVID, because a lot of the elective work is kind of on hold right now. So again, the whole idea behind that is to free up physicians to do and nurse practitioners to do televisits, but more importantly, to be available if they're needed for general medicine. So we have a very large master surge schedule that we're all on basically, and the census here has not been that high to date. So nobody's been deployed to general medicine, but there is a very large surge schedule. It's such that if we are needed, we would go up and take care of patients with general medicine conditions. Also, some of my colleagues have actually been in the intensive care unit. So even though they're oncologists, they're actually being deployed to the intensive care unit where they function under a critical care doctor, but they're really taking care of patients with COVID-19 up in the ICU. So they're the main things that we've done. So it's really been all about just limiting the number of patients coming through the clinic and the waiting rooms, but also limiting the number of providers that are in the clinic at any one time.
Wow, that's incredible. So I know you said that you're implementing a lot of phone calls with your patients, but are you also implementing telemedicine and talking to them virtually via like a webcam?
So up till now, we've done most of them just by direct phone calls, which is really very difficult and not the patients, I think, find it very tough as well. Particularly, because sometimes you have to give them very bad news over the phone. It'd be not much nice to be able to see them. So right now, effective tomorrow, we will be changing all of our telephone visits to video visits. Now, obviously, that may not be right for every patient. They may not have the technology to be able to do that, but certainly for our new patients, our aim is to, within the next week or so, to change them all to video visits. Because one of the problems with the telephone visits is that you don't know when the patient wants to talk, you can't see their face, you end up talking over them, so it's really not very satisfactory. So the video visits, I think, will be much better that way. Also, it allows their family to be on the calls too. We can do that with the phone, but it's a little bit more tricky. But with the video visits, they can have all their family there and they can ask questions as well. So I haven't done one yet myself, but some of my colleagues have, and I think they're going pretty well so far. And we're going to roll them out to the whole of our group within the next week or so.
Fantastic. And evidence has shown that COVID-19 is causing more severe symptoms in patients with coronary heart disease or hypertension. Is there any concern for patients receiving HER2-directed therapy, which often causes adverse events related to the heart?
Yeah, not that we're aware of. Obviously, a lot of our patients will be considered immunosuppressed because they're getting chemotherapy. And that's the biggest question we get all the time is, am I immunosuppressed? And very often they are, but a lot of times they're not as well. Herceptin, I think the impact on the heart is so limited that I doubt it's going to make any difference. There is maybe a thought that anthracyclines might be an issue, with COVID, but I don't think we have enough experience right now at this point to know whether that's true or not. Um, we personally treating breast cancer patients, when I'm recommending an anthracycline followed by a taxane, I'm actually starting with the taxane because that tends to lead to less immunosuppression. So the hope would be that by the time they get to getting the anthracycline, the viral issue might be over. But I don't think there's any evidence right now that any of the drugs that we use that cause cardiotoxicity do predispose patients to a worse outcome with COVID. But obviously, the chemotherapy itself can do that, and some of the diseases they have can do it too.
Great. And are you avoiding any regimens or approaching certain regimens with more caution due to the pandemic?
So we've tried to do business as usual, and we actually have been pretty successful in doing that so far because, as I say, we haven't had a huge number of cases here. We're nothing like New York or anything like that. Um, I think a couple of things we're doing. So as I mentioned, giving the taxane first followed by the anthracycline is one thing that we're doing. But for patients with estrogen receptor positive breast cancer as new diagnosis, because we don't have the same bandwidth to do surgery up front, we are putting some of those patients on preoperative endocrine therapy. So we have several patients we're doing that with, and actually that's one of the recommendations that came out of ASCO and NCCN is to think about doing that. So particularly for older patients who you really don't want to bring to the hospital and do surgery on, that's a really good option because we know that by using preoperative endocrine therapy, we can at minimum stabilize their cancer and maybe in some cases actually shrink it down, although that can take months. I would also say I think we're using the 21 gene recurrence score in the pre-opera setting more than we normally do. So again, if we have a patient with maybe a node positive estrogen receptor positive breast cancer, who we might think about giving chemotherapy to, but we're kind of thinking would they really need it? Sending on to the 21 gene recurrence score off the biopsy will give us an indication of whether they'd be better treated with preoperative endocrine therapy or preoperative chemotherapy. So there's actually quite a lot of data out there saying that you could successfully do the 21 gene score on just a biopsy. So that's certainly something that we've been doing.
Great. And so how is COVID-19 impacting clinical trials?
Yeah, so for clinical trials, that obviously has been a struggle. So the first thing that we did was we pretty much closed all of our non-therapeutic trials. So all of our prevention trials, high-risk trials, they were all closed off the bat. We have kept therapeutic trials open, not all of them, but I would say a significant number of them. All the coordinators and nurses are working from home. So what we do when the patient comes in, if it's an in-person visit, we'll just call the coordinator at home on the phone in the exam room. That's worked very well. And if it's a remote visit, what we do is the coordinator will link up a three-way call so that we can talk to the patients. And that also works for the video visits as well. So that's actually been pretty successful so far. Now, obviously, we are taking some deviations, everybody is, because there's certain things we just can't do. So for example, in studies that need research biopsies, we really a lot of times can't do those. So we'll take a deviation on that. And also because we're not seeing the patient in person and examining them, we've had to take some deviations on that, but that's what's being done universally. I think we've been able to actually function fairly well. It varies from institution to institution and obviously depends on what impact COVID is having on various institutions. But for the last 3 weeks or so, we've certainly been able to keep everybody on the clinical trials that they're on. And also, we've also enrolled some patients as well. We did temporarily close accrual to our phase 1 trials, but we are going to reopen some of them in a kind of staggered manner. And again, we're focusing on ones that we think that will be beneficial to the patients rather than ones that are perhaps just dose finding. Although it's hard to differentiate that sometimes, but I think overall our research staff have been absolutely amazing in terms of being able to adapt to this kind of new world of doing everything remotely.
That's great to hear. And some institutions are facing shortages of protective gear, including face masks and gowns. So are you experiencing any shortage at your institution? And if so, how are you dealing with it?
Yeah, so I mean, we're like everybody else. There's definitely a shortage. So, um, about I would say 3 weeks ago, we started wearing surgical masks and face shields in anytime we came in contact with a patient in the clinic, assuming a COVID negative patient. Obviously, on the patients that have COVID, we are using N95s and face masks and gowns, would be expected. There is a shortage. So for example, with the N95s, we are wearing them until they, as much as we can, or wearing them. That's what I'm looking for. So as far as the N95s, we are trying to use them for as long as we possibly can, and we are re-sanitizing some of those as well. Although they're not the ones that we would only use those if we ran out of the N95s that we have. So I think that's kind of where we're at right now. Because we haven't had a huge volume of cases here so far, I think we're fine. But like everybody else, we need more, and obviously there's a possibility of needing more ventilators as well. So one of the things to preserve the PPE, that's one of the reasons that we're kind of limiting the number of providers going in to see patients and limiting the number of patients that are being seen in person, because we can use, one person can reuse the PPE for several days. So that's why we're doing the kind of doctor of the week, and having one doctor going in and visiting these patients.
Wow, interesting. Um, and is there, have you talked to doctors from other institutions? And how does the situation at your institution compare to others?
Well, I think we've been relatively fortunate so far because our caseload has been pretty low. Our governor put in social distancing quite early on, and then the shelter from home shortly after that. Wisconsinites tend to be quite compliant, I think, so they've been very good about obeying the rules. So our numbers are pretty small right now. But talking to some colleagues in New York, it's a completely different story. You know, they are, even though they may still have an oncology inpatient service, they actually have COVID patients on that service, so they're directly interacting with those patients. So I think it really depends on the volume that you have in terms of what we're doing. But here we, as I say, we have been able to treat most of our chemo patients on time and on schedule. And we're hoping we'll continue to have the bandwidth to do that. But of course, there is a surge predicted here as well. We're not quite sure when it's going to be. But I think the predictions that we're seeing is that we will be okay for hospital beds, but like everybody else, where we may have an issue is with ICU beds. So I think overall, so far, we've been pretty fortunate, and certainly nothing like they're seeing on the East Coast for sure.
That's great to hear. And is there any research regarding COVID-19 prevention or treatment that interests you that you want to highlight?
Yes, so there's obviously a huge amount of grant applications coming out looking for COVID applications. So there's a number of my colleagues, particularly in the benign heme area, that have actually been looking at things that they could do, looking at JAK2 inhibitors, a number of kind of agents that are involved in the inflammatory, blocking down the inflammatory process, because we know that the second stage of this virus is this hyperimmune state that causes a lot of the issues that lead to patients ending up in the intensive care unit. Um, we are certainly on the cancer control side. We have people looking to see how the televisits and how COVID is impacting our cancer patients. So we have some projects ongoing in that area as well. I think some things will be interesting. For example, we're not doing screening mammograms right now. How that's going to impact what happens later on in the year, we don't know. So I think I would imagine that a lot of cancer-related projects will kind of develop as time goes on, and we see how this is kind of impacting our practice. But I think overall there's a lot of interest in agents that can damp down that hyperimmune response that causes really most of the issues that patients experience. So um, within our Department of Medicine, we have a number of kind of projects that we're looking at, clinical trials we're looking at. I think one of the issues is it's hard to know when you actually start these agents, because if you start them too early, you could blunt the immune response to the virus, versus waiting until the immune response kind of becomes hyperactive. So I think there are some of the things that people are struggling with.
That's really interesting. And How can people support healthcare professionals and patients with cancer during the pandemic?
Well, I think the most important thing they can do is continue the social distancing because obviously, if the numbers are low, that means we can continue our business as usual. Other things to keep in mind is that there is blood shortages out there, so giving blood is something I think that people could consider if they're comfortable going in to give blood. I think that would be a great thing. Um, and then I think, obviously we're hoping that from a leadership level that we'll get more PPE and other things we need to take care of the patients. But I think the most important thing, at least in Wisconsin, is for people to do what they're doing now, which is social distancing and keeping the numbers down and the curve flat.
Great. And ASCO has made the decision to host a virtual meeting. What are your thoughts on this, and how do you think it will impact your experience with the conference?
So I think it's going to be very interesting. Obviously, AACR was the first one to first big meeting in cancer to kind of postpone, if you like. I think that was the right thing to do. Absolutely, I think having whatever the amount that go to ASCO now, like 30,000 people in the current place, would have been the worst thing for social distancing possible. So I think it had to be done. It'll be interesting to see how it goes. I think we're all really learning to live in this virtual world. So the fact that there's some lead time going into ASCO and that it's at the end of May, I think we have enough time to kind of get things up and running. Obviously, it won't be the same. A lot of the reasons that we like going to ASCO is because we like to network with people, and we won't be able to do that very well. But again, I don't see any reason why you can't set up, virtual meetings away from ASCO, where we could actually talk about new trial concepts and those type of things. So I think we have to make it work. It's certainly not going to be the same, but I think we're all getting very used to actually, looking at grand rounds virtually and kind of, doing all our education virtually. So I don't see why it won't work. It will certainly will be different, but I think it'll be very interesting to see, and I'm really looking forward to seeing how it works out.
Great. And are there any studies that are going to be presented at ASCO that you're interested to hear the results of?
I actually have not really even thought about it because we weren't sure what was going to happen to it. So off the top of my head, for breast, I'm not sure of any big trials that will be presented, but I could be wrong there because I just haven't had a chance to kind of focus on what they were going to present.
That is completely understandable. Is there anything else regarding COVID-19 and how it's impacting your practice that you want to talk about that I haven't asked you?
No, I think we're coping pretty well. I think the video visits will be key for patients. I'm really excited to start getting that up and running. I mean, it's hard for a patient when you're hearing from a physician at the end of the phone that you need chemotherapy. You can't even see what they look like. I think it's very hard on them that way. But we're hoping that we'll just keep these numbers low and we can continue to operate the way we've been doing. And as I say, if a surge hits, I think we're pretty well prepared for it.
Well, that's great to hear. Thank you so much for taking the time to speak with me today. I really appreciate it.
Well, thank you very much, Ellie. I appreciate it too.
Of course. And I hope you have a good day. Thank you.
You too. Thanks.